can get, which we won't talk about in that much detail for this EFAST purpose. But we do want to talk about that B lines are the other artifact that you should know about. So usually you're taught A lines and then B lines, and A lines means air, and B lines. Anyone tell me what B lines means, typically?
Vertical line.
And so you got your horizontal A lines.
A line, horizontal,
vertical B line.
More than 3, I
Pulmonary
think.
edema.
Yeah, exactly. So yes, I was talking about the criteria for B lines. You need to have more than 3 per pleural line field.
All the way from the top to...
Yeah, and that they have to reach all the way from the pleural line to the end of the screen. Perfect. And what does it usually indicate? If you were to see this, what does it mean for the patient?
There's a fluid in the
Fluid.
There's something other than air. So
Yeah,
it could
perfect.
be a fluid, it could be a consolidation, pus abscess.
Yeah, Mia. So usually means
The patient is overloaded.
Mhm,
There's
yeah.
something over the lung capacity.
Exactly. So something is replacing the air. Most of the time in our setting, especially with all of our CHF patients, it means pulmonary edema or fluid. Sometimes it can be, you can see it in patients with fibrosis, in certain types of pneumonia, because sometimes you see consolidation as hepatization, sometimes it looks like B
In
lines.
pneumonia, it's very popular, by the way, especially the consolidation and the sometimes the B lines. So when we in the critical setting, we are treating the patient and making follow-up of the ultrasound, we need the patient to be wet. So whenever we're not seeing these lines, means we are successfully treated the patient. So the
Yeah.
patient between his in B lines means still is active on his pathology, as his pneumonia, contusion, consolidation, overloaded. But whenever we are finding that the patient no B lines, mean the patient wet, mean the patient successfully already we withdraw all the fluids or the mechanism itself that did this fluid.
Yeah,
Yes.
perfect. Yeah, so using like serial ultrasounds to help to identify the treatment course and how the patient is doing. In the setting of trauma, you often will see it in pulmonary contusions. And actually, I found this really helpful during traumas, especially as when I was working in Indonesian hospital, because there's no CT available. You would see patients when you listen with the stethoscope, that they have decreased lung sliding after an explosive injury or something, and then the usual protocol is if you hear decreased lung sounds, just put in a chest tube. But then if we had the ultrasound available, we just took a look at the handheld ultrasounds. It had the eagle view, just like the one that Dr. Bing has.
Yeah.
And then you see this, you actually know, oh, it's a contusion. You can save them from the traumatic chest tube. You can save them from the infection risk, and that was very helpful because that when you see B lines in a trauma patient, that means pulmonary contusion, and it also means that there's no pneumothorax in this spot, because you actually need the pleural to be touching to create the B line. If it's not touching, then it's not going to make a B line, so you know there's no pneumothorax in that area. One thing that confused me a lot in the beginning is why does pulmonary edema create B lines, and then a pleural effusion or a hemothorax, which is also fluid, looks completely different. And the main thing is that the B lines are created from intraalveolar fluid or intraalveolar edema, whereas an effusion or hemothorax is outside of the lung.
And just blue.
Exactly. So this is what you guys already talked about, which is that there's certain criteria for what is a B line, because you'll sometimes see little specks, like little lines in your regular lung ultrasound, and that doesn't necessarily all mean B lines. B lines have specific criteria. They should be vertical, like you're saying. They should be going from the top of the screen to the bottom, and they should also, there should be 3 in each pleural field. Although sometimes I've found that sometimes it looks like there's one, but it's like one giant one. It's because they became confluent. So I'd say that rule is like a little bit soft, but they also have to obscure. You shouldn't see A lines the same place you see B lines, so they should basically cross out the A lines, and they should go from the top to the bottom of the screen. Okay, so then a review of our hemothorax evaluation. So we did this we taught this as part of the abdominal ultrasound because you're already in that spot. So you just look over the diaphragm to see it. But a review of that, because it's part of the chest, is that you look for your hemothorax in the more dependent area by the diaphragm. And then, can you tell me what this picture is? Normal or not normal?
Yeah. Not seeing any good. Here's a few fluid.
So this one does have fluid. Oh, so here's the. This is either liver or spleen. This is the diaphragm.
Maybe this line.
So it
Is
looks
the fluid
like
here?
yeah, it looks like there's fluid here. This looks like it could be maybe a clot or some kind of dense material.
Yeah.
And then one other clue.
Spine sign.
Yep.
Normally, I should not visualize the spine sign. So whenever there is a fluid, so there is a duplication of the spine, so you can find like spine
Perfect. Yeah.
above the diaphragm.
So Rowan said this is the spine sign, and she gave the perfect definition for it. So this one is the normal example. So you have your kidney, lung, your diaphragm, and then here's the patient's spine. It's actually these stents vertebra that you're seeing, and then because there's air filling this area, it actually stops the signal from allowing you to see more of the spine above the diaphragm. So if you have an expanded lung, if you have air over the diaphragm, the spine, you don't see the spine go up higher because the air disrupts the signal. Whereas when there's a hemothorax or a pleural effusion, you'll see the spine sign, which means the spine is continuing past the diaphragm. Perfect. Any questions about that? So this is what a hemothorax might look like, but it would be in a different area. You'd be looking in the more dependent part of the lung. So there's many different protocols for how to scan a patient when you're doing lung ultrasound. There's people that will like scan the entire area of the lung in the chest. In the ER, if you're looking at just the lung, then typically you'll look in 6 areas, which is the anterior, top, bottom, symmetrically, and then the sagittal, and then the back. But for the purpose of the EFAST, you're only really looking at the upper zones because you're keeping your lower zones as part of the abdominal. So here's a summary of the EFAST views. You have, remember the abdominal ones, right upper quadrant, left upper quadrant, your epigastric, and your pelvic. And then your these are the 2 chest views, which are going to be your apical views because you already included the more dependent views in your abdominal ultrasound. And then next we're going to talk about the cardiac view, and that we're looking for the pericardial effusion and pericardial and possible cardiac tamponade. So there's a lot of times when a patient is hypotensive and there's no pneumothorax and a negative abdominal fast, another possibility is that they could become hypotensive because of a pericardial effusion causing a tamponade. And in trauma patients, because this accumulates, the blood can accumulate very quickly, you actually can have a pretty small amount of fluid in the pericardial space, and that can actually cause the patient to be hypotensive and unstable. We see that a lot here because there can be, a patient can get even like a small cut or a small wound from a shrapnel and then have some bleeding in here that can accumulate. The classic teaching is that it accumulates quickly in trauma because the typical teaching from textbooks comes from gunshot wounds and
Shrapnels.
But we've seen that with sometimes the blast injuries, maybe the shock wave or from the smaller shrapnels, the patients that survive from a cardiac injury and make it to the ER actually can have more subtle findings compared to what's what's interesting is like here we're actually on the cutting edge of some of that information, and even Dr. Kajil and the ER team published a paper on how they're managing these pericardial tamponades and effusions. So the view for your subxiphoid view of the heart is that you're looking from the abdomen into the heart. So rather than the cardiac views that you've probably seen with cardiology, Dr. Hazem, where he's looking from the top, for the purpose of looking for pericardial effusion, the best view is from the subxiphoid because this is the more dependent part, and that's where fluid would usually collect first in the space between the heart and the diaphragm. And in order to get that view, you have to change your orientation of the probe. So for the FAST exam, we taught that your probe should be held at 90 degrees for the most part until you're fanning and rocking. But for the subxiphoid view, you actually have to start with an angle. So for example, you want to go here with your probe, and the heart's here, if I have one. And so you're actually angling your probe towards the heart. You also have to push down into the patient. So you're kind of doing this motion. Usually you hold the probe like this, like a pencil, but for the subxiphoid view, usually you go overhand so that we can push
Have full
down.
more power.
And then when Dr. Fahed explains during practice, it'll make more sense
Yes.
when you do it hands-on.
Yeah, yeah.
And you want to orientate towards the patient's left shoulder, and usually it's a bit of looking around. You actually want to usually find the liver first, like you'll see the liver, and then above the liver, the heart.
Yeah.
And the liver kind of helps you form an acoustic window. So here's the liver, and then after the liver, it helps to enhance the image of the heart. So this is just the illustration of the view that you have. We won't bother going through the chambers and stuff, because that's not what we're looking for. But here's a normal example. So the probe's here, you're pushing down, the patient's saying, ouch, stop that, because they universally hate this when you're pushing on their belly. And then it goes to the liver, you see the pericardium just like sitting on the liver. So it should be, normal is that there's no fluid, similar to just like the abdominal fast, you're looking for the free fluid kind of picture. And here you don't see the free fluid, it's just the heart adjacent to the liver, and then you see the chambers here. Okay. So again, you're only answering that one question, effusion or not. So what do we think of this image? And this
And the cloth?
so there's, and then you said clot too, so there's also a clot in this stage. And you can see that the chambers, so this is the physiology, or the pathophysiology. What happens is that the fluid's actually pushing onto the right side of the heart, the RV and the RA. And exactly. So here again, what do we think? What about this one?
Swimming.
It's swimming, yeah.
Swimming.
Yeah.
Swimming sign.
Yep.
Yes.
So the heart is swimming.
Swimming.
Yeah.
This is called the
This is
swimming
so-
sign even. Yeah, swimming heart sign. Yes. Which means this is related to massive pericardial effusion.
Yeah.
Sure,
That's
yes.
subxiphoid or what is?
And then this one is actually, it's also positive.
It's
but
positive.
Mhm. This
But
is trace fluid here.
Trace.
And this is
Yeah,
a bit of a clot again. So sometimes it can be subtle, so it can be very obvious sometimes, and it can be a little bit more subtle sometimes too.
Yes.
And whether it's something you need to intervene on right away, whether it's a tamponade versus just a trace effusion that can be observed. Because sometimes the small effusion, if there's no tamponade, the patient's stable, you can observe it. The main way to make a decision is to look at the vital signs and the way the patient looks. There's other more advanced ways to do the echo and look at the way the wall is moving, but we aren't going to go into that because it's we have to first talk about like cardiac echoes before that.
Do
Yes.
we have any idea what that blood pressure is on in the swimming zone?
No. Hypertensive? No, no.
Actually,
It's
not
not. It's not
necessarily.
mandatory. No, no, no,
Yeah.
no, no. I'll speak about this, but after finishing, I'll speak about
Yeah.
the pericardial effusion now. Okay. You just finished the what
Let me
you
wrap up.
the rest of these slides, please. Yes.
Okay, so the summary, we're wrapping up. We talked about all the components of the EFAST exam now. Dr. Fahed explained about right upper quadrant, left upper quadrant, and pelvic, and also introduced us to the subxiphoid view last time for the abdomen. So we know for the right upper, left upper quadrant, we're basically asking the question of is there free fluid in that area in the abdomen, and also is there hemothorax. For our pelvic view, we're asking is there free fluid in the pelvis, right apical lung and left apical lung. At the more apical section, whether it's they're sitting up or they're laying flat, is there hemothorax, and then our subxiphoid is there pericardial effusion. So we're mainly finding things that need to be intervened on right away that can cause hypotension in a trauma patient. Again, your EFAST exam, despite including a lot of information, it won't find any bleeding in the retroperitoneal space necessarily. You might see signs of it, like around your kidney, it might look strange on your FAST exam, but it's not that sensitive for retroperitoneal bleeding, which is also a space that you can hemorrhage out of. And it's not, and obviously if you're bleeding into your thigh or hemorrhaging from an extremity, it's not going to help you with that. So again, keep your clinical picture in mind. It's important, but if the patient needs an intervention right away that's not included you don't delay a patient's interventions for doing the EFAST. Okay. And now, Dr. Fahed's beautiful face. He's going to explain more.
Thank you.
Thank you.
About the-
Thank you very much.